Okay, good evening and welcome everyone to the fourth episode of the UCT Division of Global Surgery and the UCT Surgical Society Global Surgery webinar series. If you've been tracking with us over the past little while, you know that the past three webinars we have presented a kind of tour de force in global surgery, aiming to give relevant insights and knowledge to all attendees that can help further access to safe, quality, and affordable surgery. So far, we've been privileged to have people from various disciplines throughout the surgical practice, including health management. But this evening, we're delighted to have with you all the first medicine specialist of the series presents. If you know anything about Prof. Mpiko Ntsekhe or Prof. Lydia Cairncross, then you'll know how excellent they are at thinking, leading, and innovating in their practices. A reminder that if you want to watch the previous webinars, they are all up on YouTube. You can find them by searching UCT Surgical Society. I'm absolutely confident that all of us will leave this session today feeling challenged, stimulated, and inspired to continue learning and growing our own abilities to build up the health of our communities. So with that said, I'll hand over to Prof. Ntsekhe to introduce today's topic and speakers. Thank you, Prof.
Right. Thank you very much, Regan, and welcome to all of you. And, you know, the past few weeks have really been a journey about global surgery, what it is. And so we started off looking at what global surgery is, the definition. We looked at it from a public health perspective, from a primary healthcare perspective. But today we're looking really at the global part of global surgery. And I want us to look at it from a population health perspective. So on two levels, the one level is, you know, global surgery is all about improving surgical outcomes in different populations. So it's not just looking at what we are doing in our center or just looking at this country, but it's looking across the continent, across the world. Where do we fit in when we look at surgical outcomes across the world? But the other part of it is global surgery is all about partnerships. And that's how, you know, even if you look at the population health definition, it's about transdisciplinary partnerships and how we can all work together in non-traditional ways to improve health outcomes. And in this case, it's surgical outcomes. So today we're really excited about this talk because we're going to look at at global partnerships, at the global dynamics, how to reset that, and looking at the different power dynamics. But I think the whole thing, what we want to introduce is the whole idea of global partnerships and how we can all work together across countries, across institutions to improve surgical outcomes. And so we've got a perfect example here, because in global surgery, we don't work in silos, we work across disciplines. And hence having a speaker from the medicine department, from cardiology, and of course, our own Prof. Cairncross from the surgical division. So it's really about breaking the silos, looking at healthcare, you know, through a different lens, and bringing together all the key players that we work with to improve healthcare together. So I won't take too much of your time. I'll close up again at the end and tie up some of the important themes that are gonna come up. But I'd like to immediately hand over to Prof. Ntsekhe, who's the head of cardiology at UCT. And yes, handing over to you to tell us a bit about power dynamics, but from more of an education perspective, and Lydia will look at it from a different lens. Thank you.
Okay, great. Thanks, Regan and Salome, and thanks for inviting me to this very important series. Let me just load my talk, put it on speaker mode. Okay, so as I said, thanks for the invitation and the introduction. So before going further into the talk, what I'm going to do is make these declarations of my conflicts of interest, which I don't have any, except to say, of course, that as you heard, I'm neither a surgeon or a public health specialist. I don't have any formal or informal training, for that matter, in global health and global surgery as a discipline. So what I'm going to try and do today is just bring a sort of personal perspective as a physician, cardiologist, and citizen from the global south. So Regan asked me to address a number of things, three in particular. He said, what are some of the power dynamics in global partnerships as they relate to capacity building and training of healthcare workers in Africa and the global South? And how can we in Africa reset these power dynamics? And is there any role for innovation and education to help improve access and availability? Let's see how we move this on. So power dynamics. So given that this is a central theme of today's talk, I thought I would just give you my perspective on what we're talking about. So first of all, what is power? And for me, it's the ability to leverage undue control and influence over others based on a perceived or real asymmetry in the relationship. And sometimes this is resource, it can be knowledge, race, gender, language, age, colonial past, and neo-colonial present. So a whole host of factors can play a role in in what constitutes power. And the power dynamic really simply describes how this undue control and influence affects both the relationship and the intended purpose or goal. And the power dynamic is often the unspoken or unacknowledged elephant in the room in any partnership. I think it's important to point out that power dynamics exist in all relationships and therefore inherent in all partnerships. So if we look at the role of global partnerships and global surgery, as Salome said, they are absolutely critical. And as a recognition of the dire need for access and availability for safe and quality surgery has grown with the Lancet Commission and other things that have precipitated the momentum, there's really been an explosion of interest in global surgery in the global north and actually around the world. And clearly the potential to harness all that energy and enthusiasm and help address this global health crisis is hugely significant. Okay. However, if we acknowledge that if global partnerships are critical to achieving the goals of global surgery, which we've discussed over the last few weeks, then recognizing and resetting some of these power dynamics is itself going to be critically important. And part of what I'm going to be talking about is pointing out that if left unchecked, i.e. if we don't identify, acknowledge, and try and reset some of these power dynamics, then it can lead to a host of unintended consequences, many of which might not be suitable or desirable, particularly for the lower and middle income country. And they may in fact perpetuate or exacerbate the original problem, which in this case, of course, is lack of safe and quality surgery. So what do these global partnerships look like? Generally, in the teaching space, they usually involve sort of individual teaching efforts. So you might get individual surgeon or clinician with a passion, leaving wherever they are to come and give some time and then some time. Sometimes they involve twinning of hospitals, one hospital obviously in the high income country and the other in the lower income country. And the idea here again is a skills transfer with mentorship, supervision, ability to discuss cases at long distance. And there's also been growing sort of global surgical academic collaborations. And these usually involve a number of things, including research, residency programs, and the provision of care. So in a sort of classical exchange partnership, what you get is an individual or a team from the HIC, I'll just call it a HIC, which partners with an LMIC country. And usually, of course, the intentions are noble and are in keeping with the spirit of global surgery and its intentions. And these include to perform procedures on local patients who, of course, don't have any access, to teach local healthcare workers how to perform the procedures, whatever they may be, X, Y, Z. They involve setting up curricula for teaching and training, setting up or trying to set standards of care, providing mentorship and supervision to these local healthcare workers. And often the duration of engagement is quite variable. And I should say that sort of mission short-term visits are now falling out of favor. And in the process of doing all of this is usually, there may be conduct of research and ideally teaching of research skills. But of course, in all of this are potential pitfalls. And so we can look at the potential pitfalls of this classic exchange partnership. And I thought in particular, this experience shared by a global surgical fellow from the Northern Hemisphere in the BMJ was particularly insightful for highlighting some of the issues. Okay, so what he describes is before leaving on his Caribbean sojourn, he attended a series of prep lectures on his destination country to try and sort of prepare him for his journey ahead. And what he noted was none of the lectures were given by people from that country or people who were intimately familiar with the setting and what he was heading to. He said none of the lectures addressed issues of the local culture, the language differences, and local perspectives of health and healthcare and healthcare needs. None of the lectures addressed the issues of the structural asymmetries inherent in the exchange that he was about to undertake and the potential implications. For example, here he was a junior registrar who was going to be thrown into an environment where by just virtue of where he came from, what he looked like, he was likely to be seen as a savior, a messiah, or the big boss. None of the lectures address why poverty, health inequality, the lack of access was such a chronic and persistent problem where he was going, and the role of the global north, and in particular his country, in perpetuating the problem. Okay, and none of the lectures address potential long-term structural solutions. And this all left him feeling very ill-prepared and uncomfortable with his experience as he reflected back on some of the things that could have been improved on. So one of the things with this classic exchange partnership is that they're often seen through the lens where the educational and training framework is looked at through that of the HIC. And the focus of the partnership is very often exposure, experience, and career development of the visitor, and not necessarily on the long-term capacity build and development of the locals. Sometimes the guidelines and the recommendations are very much steeped in global north practice and do not always consider the local realities or local context. Many surgical innovations currently in use in the global north and considered standard of care there may be more expensive, maybe more demanding of technology, maybe more resource intensive, and not always sustainable or appropriate in LMICs. And sometimes alternative expensive but efficacious strategies are not considered or not used because they're out of favor in the HIC. And a prime example of this, although not sort of basic surgery, is the difference between on-pump bypass surgery versus off-pump bypass surgery. So the global north doesn't believe in surgery on a beating heart because of marginal differences in long-term outcome. But in places like India, it's revolutionized access for many of their poor, and they're able, for the price of one surgery in the global north, to operate on sometimes hundreds of patients by exchanging efficiency for small margins in efficacy. So questions that are not frequently raised or discussed when these partnerships are formed are, is the partnership long-term? Is it going to be collaborative? Does it embrace equity and reciprocity? What are the long-term goals? These are very important to define up front. And in whose interest are they? What is the end game? Is there an idea where hopefully at the end you've trained and capacity built enough that you can exit and go elsewhere? What will be the will there be opportunities for exchange? I think that reciprocity and the idea where possible and others can go and learn. And so there's an exchange in learning, not just one-way traffic. Will the visitors be willing to learn local language, customs, culture? Some of these questions are not always asked. In addition, important questions such as who will identify and define what exactly the skills training care needs are? Who will set the medical surgical training curricula? Who will set the standards? I gave the example of where the standard was really one from the north as opposed to one for the south. And who decides when the locals are competent? So importantly, if these power dynamics are not acknowledged and not reset and not discussed up front, again, other well-described potential consequences include potential disruption of the trust that locals have in their own doctors and in their own health system. Sort of an inferiority complex has been described within local caregivers. And disruption of local flow and infrastructure. So sometimes resources are diverted away from usual practice to please partners. Low morale amongst local healthcare workers, and little progress in the original problem if some of these things are not addressed upfront. So in a nutshell, for this part of it, it's really about remembering that members of the partnership must be prepared to acknowledge the elephant in the room, and they must be prepared to allow members of the partnership to have an equal voice, express their agency with equal power, and engage on an equal footing with mutual respect. Okay, and we can explore some of these things further. To end on a more positive note around this, I think there is recognition that these power dynamics can have a negative influence if not addressed. And exploration of the literature shows that articles like this and people are really trying to address it. So a time for a new North-South relationship in global health. These type of commentaries are quite common now. So in terms of the other thing that Regan asked me to look at was the role of South-South partnerships in shifting the reliance on the global North and resetting the power dynamic. And I thought I would share a local example and local experience. So excuse the cardiology for those of you that are not so inclined, but complete heart block has a prevalence of about 0.04% in the general population. Of course, this rises significantly in those over 60. And this is independent of geography, race, ethnicity, and all these factors. And in fact, it's a major cause of sudden cardiac death, of course, in the elderly. The annual mortality following diagnosis of complete heart block is 60%. So that is greater than most cardiac conditions. We often get concerned when people have had a heart attack, but the annual mortality of that in someone who's well treated is less than 10%. So in 2010, only 16 out of the 53 countries on the African continent were able to offer its citizens permanent pacing. And what's important about this is permanent pacemakers can restore individuals to their pre-complete heart block survival curve. So you can take a condition with an annual mortality rate of 60% and restore it to age-matched control survival. So barriers to the availability of pacing from a trained healthcare worker point of view included that the standard that had been set was that you had to be a fully trained cardiologist to be able to insert pacemakers. And of course, this means minimum of 7 years post-community service training. Of course, cardiology training programs are few and far between in sub-Saharan Africa. It's very difficult to get into any training programs in North America and Europe. The cost of training is often prohibitive. And the other barrier had been, of course, the cost of new device, which was seen as prohibitive in many of these countries. So in 2012, we here at UCT Cardiology, and I must say here that this was our late dean's brainchild, Professor Mayosi. So we set up a training partnership with the Pan-African Society of Cardiology, and where UCT and PASCA fundraise through philanthropic organizations and industry. We used PASCA and the power of PASCA to engage with governments with regard to prohibitive legislation and a commitment to some basic infrastructure, including allowing them to import reused pacemakers after publishing our own 20-year experience demonstrating excellent results with reused pacemakers. So the model basically was that we, physicians and surgeons and medical officers that were experienced could come to Cape Town for 69 months, along with a clinical technologist. The PASCA assisted with HPCSA registration, and when they arrived, they got integrated into the pacing team. And of course, there'd been a centrally agreed curriculum with target number of pacemakers, etc. And actually, in 2014, we had our very first successful graduate from Sierra Leone, and we've been graduating 2 such people per year until last year. And most importantly, since then, having demonstrated that the model worked, we were able to set up 3 more hubs. So we now have an East African hub, a North African hub, and a West African hub. And so as a result, over this very short period of time, pacemaker insertion is now available to 12 additional countries. So this has been quite an achievement, and this experience was recently published in the Journal of American Cardiology International. So with that example of a South-South partnership that has been quite successful, I will end my discussion. Thank you.
Thank you so much, Prof. Ntsekhe. I think you gave a really excellent presentation, which I'm sure will continue in the question and answer session afterwards. I think your slide about the questions that aren't frequently asked should be sort of a mandated thinking exercise for all high-income country training programs that have roots in the Global South. Thank you so much for that. I'm going to hand over to Prof. Cairncross to continue presenting. Thank you, Prof.
Hi, good afternoon, everybody, and thank you very much for this invitation. Let me just get my slideshow up properly. Yeah, thank you very much. So I think this is a really important conversation, and Mpiko, thank you for covering really the foundation of some of what I wanted to say as well. I'm going to focus more on the research and implementation aspect, and there is quite a lot of overlap with some of the surgical missions that's already been discussed. But before I begin, I thought we should really look at, when we're talking about resetting power dynamics, where are these power dynamics coming from? And it's always sobering to look at our colonial history and the impact it has on the way the world looks today. And to remind ourselves that over a period of 500 years, Europe really conquered most of Asia, Africa, and America. And specifically relevant to us, that the British Empire between the 16th and the 18th century really reset the way the world looked. And by 1913, 23% of the world's population and 24% of the Earth's total land area was under the control of the British Empire. And that colonial conquest was multifaceted. It was not just about armies that came in. So there was a process of military conquest, yes, men with guns. But there was also economic conquest, which was seizure of land and mineral wealth. In South Africa, that would be diamonds and gold. There was social conquest, so the subjugation of indigenous populations, creation of the other as an object, removal of culture and language, and a new religion imposed. Political conquest in the form of new laws, criminal justice systems, and excluding the disenfranchised from the systems of power. And the last bullet point there is colonization of the mind through processes like the formal education system, for us to learn that the normative is European, is white, and is male. And unthinkingly, we still keep many of these reference points in the way that we do our work. And of course, education and healthcare was part of this colonial process. In the University of Cape Town, we have a university that was established about 100 years ago by land which was bequeathed by one of the biggest colonialists, Cecil John Rhodes. And we know that beyond the tertiary education system, the education system as a whole was really set up to support the colonial project, and that had its ramifications in South Africa with Bantu education and, you know, the way that we teach our young. is to maintain those conditions of privilege and power. And then in the field of medicine, it's important for us to remember that medicine is not politically neutral. That Western biomedicine, which is what we train in and we learn and we research in, was also rolled out together with the Colonial project, and that many of the influences and sources of knowledge that is called Western biomedicine, in fact, came from outside of Europe, but became integrated into and appropriated really into what became Western medicine. And that the normative there, once again, was predominantly male, the 70-kilogram male, and predominantly white as the normative body form. And then together with that was the suppression, inhibition, and arrested development of indigenous healing and knowledge systems. And that's not that long ago. So 1913 is just over 100 years ago. And that might all be history, but we can see the current impact in the way that the world works today. And the Oxfam report on global inequality is always a sobering read. The 22 richest men in the world have the equivalent wealth of all the women in Africa. And at the bottom there, the 2 richest South Africans combined have the same wealth as 50% of our population. That is Nikki Oppenheimer and Johan Rupert, by the way. And we know this graph very well, that South Africa is right up at the top of inequality. That's because we have wealth in this country, but we have profound poverty as well. And it's the gap between the rich and the poor that makes our society so unstable and so volatile. I want to quote now and talk a little bit about global health, and because I think many of the partnerships we're talking about in global surgery and in addressing health inequality are influenced by the origins of global health. And Dr. C.A. Abimbola is the editor of BMJ Global Health. He's a Nigerian doctor and public health specialist who works for the BMJ, so there's also that. And he caricatured the global health definitions and where it came from, saying that when global health first started, it was called tropical medicine, Global Health 1.0, which was about keeping white people and subsequently the labor force alive in the tropics. And then with time and a shift, global health became Global Health 2, which was also called international health, which was about clever people in high-income countries helping poor people in low and middle-income countries. He then moves on to Global Health 3, which is about people in high-income countries leading health programs in LMIC. And he ends with what he hopes will be the Global Health 4 movement, which is about people from LMICs leading their own health programs according to their own context and health needs. We also can't really talk about global partnerships in health without looking briefly at global governance in health. And the WHO and the UN are really important in this conversation. We know that there are many very laudable goals that have been put forward, such as the Millennium Development Goals and the SDGs, attempting to address many of the health issues in the world. However, these programs have not been successful in really shifting this inequality. And the programs, the UN and the WHO, are critiqued on many levels because of lack of democratic practice and the way that decision making is done and the structures within. And if you look at the funding behind these global bodies, it's not difficult to see where the power really lies. With the US as the #1 funder, though not after Trump, the #1 funder historically at over 110 million, then followed by Japan, Germany, the UK and France. And these 5 or 6 countries really are the main funders, together with a few very powerful and influential individuals such as Bill Gates. And just important to note that the WHO spends about 200 million per annum on travel, which is the same as their collective spend, more than their collective spend on HIV, TB, and malaria combined. So let's talk a little bit about how this relates to global surgery, and these are really the 3 components of global surgery that we look at here in our global surgery division here at UCT: implementation and research, Mpiko has spoken quite a lot about surgical missions. I'll just read a few quotes in relation to this. So this is regards to implementation. So when we want to implement change in global surgery, what does this mean in terms of how the power dynamics are playing out right now? And this is a quote from an ENT journal. Also, people who have been in the field and have commented on their experience and the fly-in surgical missions. And to quote, they say surgical missions can provide much needed equipment, surgical expertise, and caring professionals who do their best to confront the huge backlog of patients with disease. And at their best, they may leave better equipped departments as well as well cared for children. But at their worst, they dump expired supplies, leave sophisticated medical equipment that quickly fails, and abandon incompletely treated patients. And similarly to other global programs, there is a mismatch between the amount of money spent on actual services and that is spent on keeping the program going, with up to 50% of costs on travel. So I'll just summarize the issues around surgical missions and why we need to do this in a different way, and not spend too much time because Mpiko spoke to this. But aside from the issues he raised, there are also issues related to the power dynamics between the arriving surgical team and vulnerable communities that they come to serve. And this impacts on consent and autonomy and decision-making from a patient perspective. Often these teams are accompanied by trainees from high-income countries who are performing procedures they may not have done in their own country. And then for me, things that really worry me is post-operative care, as well as rehabilitation, long-term outcomes. And then of course, the keeping of notes, morbidity and mortality processes. And then the big issue is sustainability. So if you don't train local teams, this is not sustainable. And underlying all of this is really, it's a paternalism and a lack of acknowledgement of the capabilities of local teams. There is a shift in thinking. This is a picture of a surgeon from Nepal who trained through one of these global surgical mission teams. And that change in thinking within that particular team, Research International, took some time. And there's an article describing how the board of this particular international humanitarian organization really struggled to shift the thinking to training local surgeons rather than doing the surgery themselves for all the usual reasons related to assumptions about competence and ability. What about power dynamics in research? The study that I'm going to quote here is really a study that looked at authorship as a proxy for research capacity, and also authorship as a proxy for who is talking about the diseases that affects people in low and middle income countries. And they looked in the study at randomized controlled trials, specifically on TB, malaria, and HIV, over more than about 15 years. And they found that, first of all, the majority of studies were funded by the US. Less than 50% had a low middle income country author as the first author, and half of these studies took place in Africa. And as a proxy for research capacity, this is really a very damning study, and very worrying. If you look at the funding mostly coming from high-income countries, this speaks to the research agenda, who sets that agenda, and who has the ability to implement that agenda. There have been a number of steps that have been proposed to try and shift this in terms of authorship. So how do we make sure that this is more fair, that there's more balance in authorship? And those things can be implemented, changing inclusion criteria, academic promotion, and so on. But as in the words of Dr. Abimbola, once again, part of the problem of research is the issue of the foreign gaze. And I found this a really insightful read. It's an opinion piece about who are we writing for when we do our research, and when we perform our research, who are we doing it for? And the problem of gaze is really at the heart of the academic global health issues. Because if we are writing for an audience that is not specifically our local audience, it really means that we are negating the experience of the experts that are around us actually addressing local problems, which then means that we are not addressing our own reality. And we all know that If you're in the academic sphere and you are publishing and you are doing research, if you're publishing in a local journal, then you're publishing just in a local journal. It does not have the same impact as an international journal. But if you can do the mind shift and think that what is a local journal for the US or for the UK, that would be the NEJM or it would be the BMJ. And for us, that's not a local journal from another country. That is the journal. And those are the journals that we need to publish in. And that mindset is played out in our academic institutions, in our promotion criteria, in the way that we view all our research. It skews the way that we ask our research questions. And because we know we need to chase the funding as well, it skews the way that we do the research that we do. So my last few slides are really an attempt at looking at how do we reset. So the first one is that to really reset these power dynamics, you have to reset the global inequalities that exist, which is a big task, and it's part of the work that we need to do. And I think as health workers, we need to develop a critical analysis. We need to understand the political economy of health, understand the root causes of the problems that we see and the ongoing injustices that occur. So what is the role of the pharmaceutical industry? Looking at unethical health worker recruitment. It's deeply cynical process where surgical missions come from the north and at the same time health workers are recruited from the south to the same countries. We also need to look at the policies of big international bodies like the IMF and World Bank and how they impact on health. Then we need to decolonize our education curriculum within health. How do we learn about healthy health and the causes and consequences of ill health in relation to this global system? And I mean, to summarize all that, we need health workers that are both activists and advocates for these bigger issues. Then specific to global surgery, on the implementation cluster, and by implementation, I mean actually doing things that improve surgical outcomes. While it might feel good to become a volunteerist and go to another part of the country or another part of the world to go and do 20 operations and then come home, we must resist that temptation, because there is a temptation for South Africa as well to develop that kind of relationship with the rest of the continent. So we must make sure that what we implement is person-centered, community-centered, and country-centered, so that we are delivering the care that is required, not the care that we want to take to a particular place or a particular part of our country. We need to encourage South-South collaborations at all times. And as I said, we need to be wary of the power dynamics between ourselves and the rest of our continent. Essentially, we need to change the surgical missions into training partnerships. And this really takes a mindset shift, because training partnership really has to be a partnership. It's not about one group of people going to learn from another group of people, but a recognition that each side of the training partnership is an expert. So people in their local context, like for example, us here in our local context, we are experts in our health needs and in our health context and what we need to do in order to train. Someone may have the technical expertise on a particular issue or be able to do a particular operation. And that exchange of expertise is what we mean by an equal partnership. Implementation strategies need to be sustainable, and they need to look at the systems. So flying in and doing 100 cataract operations does not necessarily set up the systems for the diagnosis of cataracts, for ensuring there's a transport system for patients to come to hospital, making sure there's good anesthetic equipment and trained nurses for perioperative care. So a systems approach is the only way to make a sustainable difference. And then I think we need to start to demand much more that resources need to shift from high-income countries to support South-South partnerships, like the partnership that Mpiko has described. The money for that should be coming from HICs, but it should not be for their particular surgeons necessarily to come here or for us to go there to train, but for there to be funding for South-South partnerships between our colleagues in Brazil, in India, and countries that may have similar resource challenges and dynamics to our own. And then lastly, resetting the agenda for research. I think we need to shift our focus on research for publication towards research for action and change, and shift our gaze So have an Afrocentric rather than a foreign gaze approach to our research. That means that we value, support, and reward local research as valuable, and that we need to change our academic institutions to reflect that, including promotion criteria, how we rate researchers and how the NRF does that, and how we decide who becomes a professor. And as colleagues here in the South, we need to be bold about our engagement with our Northern Hemisphere partners for how they resource the local research work that's centered on our particular agenda and not on a program of research that's been developed elsewhere and the protocol arrives and we're here just to implement. So in conclusion, I think resetting the dynamics and the power dynamics is about shifting and becoming ethical in all the domains of our work. That we need to be transparent in the way that we do global surgery, that we need accountability, both accountability of ourselves to those that we are serving, as well as demanding accountability between ourselves and our partners. And of course, we need to be of service as well to the patients whose lives we are trying to change. And that applies to research, which should be research for action and change, not publication. It applies to education, which should be education for service. And it applies to implementation, which is really measured by what difference we've actually made to people's lives on the ground. Thank you so much.
Thank you so much for that, Prof. Cairncross. You gave a brilliant theoretical background to understanding these health partnerships. And I think it's against that background, I think it was your first slide about the WHO and about coloniality, is against that background is where I want to bring the first question. So if you and Prof. Ntsekhe could both comment, even Prof. Mswime, if you have anything to add. And the question is that how do we, as low and middle income health workers and institutional leaders, avoid or mitigate against colonial approaches to health partnerships? And I think you spoke a bit about it at the end of your presentation, Prof. Cairncross. But I think a lot of the problem comes in with this idea that Prof. Ntsekhe gave us in the beginning as a defining power, as the ability to leverage undue control and influence over others. So how do we mitigate against that if there is that power dynamic?
Do you want me to come in first, Regan, or? So I think it's not an easy answer, because the power also follows the resources. So I think part of it is about demanding more boldly and more clearly that those resources and the resource inequities are ill-gotten gains, and we need to talk about that and say that there are programs that need to be run, and that the content of those programs should be determined by LMIC countries, and the resources should come from northern partners. So some of these partnerships are beginning to look at that, but we are quite hesitant and reticent to make those statements and to make those requests very clear. So we tend to be in awe of the Harvards and the Stanfords and Oxfords, and if someone comes to us with a project from one of those universities, everything gets dropped and that's what we're going to do. And I think we must shift that thinking ourselves and say, that's a great project, but actually what we need funding for is this project, which is relevant to our problem right here in our country. So part of it starts with us.
Yeah, so I would have to agree and go back to my sort of thesis about the elephant in the room. I mean, I think the starting point is, as the partnership is born and it comes with the baggage that it comes with, we need to be bold up front about recognizing what the elephant is and being able to speak to it. I think I pointed out at the beginning that many of, I mean, the lens through which many of these partnerships are driven is, where is the opportunity for the HIC, right? So Lydia spoke about the fact that many people come over here and are able to do procedures that they would never be able to do in their home countries at a much earlier stage, in much bigger volumes. They get promotions because they've spent time overseas. They get to do research that they might not have others. So seen through that lens, a lot of the focus of the partnership and its intention is driven by that. Okay, and so I think it's very much about a change in mindset, about reclaiming that space, about, it is possible to say, actually, we're not going to accept this partnership, and we will find other people who are going to put our priorities first. We're going to recognize that when we started out, we said this is about making surgery safe and making sure that there's quality surgery and all of that, of what that entails. And that's what the be all and end all of the focus should be. And the other things can be, they're important, but they should be secondary rather than the other way around. I think many of their partnerships start with slightly different intentions. Whether they're intentional or not, it is about mindsets. So I think we need to shift our mindset, and in the process of shifting our mindset, recognize that we do have voice, we do have agency, and we should bring that to the table up front and be bold about it. And I think, some of the examples Lydia gave in terms of the Nepal program and other places where people are shifting has not been voluntary, but it has been about a sustained effort to make them realize that there is this dynamic and it does need to change.
And I'll just add quickly, I mean, it's not that we're saying that we don't want partnerships. We a lot of health work, no country is going to solve its problems on its own. We do a lot of work, and we work with institutions with each other around the country, different provinces, etc. We work with different countries, we work with international organizations. That's important. But I think what's really important is that it needs to be equal partnerships, lateral partnerships, and it needs to be and there needs to be equity, and they need to be ethical, and it's highlighting those things because historically a lot has gone wrong, and a lot of people, a lot of partners from the LMIC have been, have suffered silently, being part of, simply contributing data, for example, to big research studies, but none of it actually improving the outcomes or improving or changing how things are going to be done or impacting change in that country. So I think it's going back to looking at, when you start a partnership, let's have an honest conversation about what do we want to achieve together, who brings what to the table, and have an equal partnership going.
Yeah, I think it's great that I really like the focus being and the gaze being on what can we do, how can we as researchers or health workers, sort of demand and be bold about that upfront. All three of you have huge amounts of experience in this sort of regard. What is the response from funding partners or high-income country academic institutions when these sorts of priorities are laid bare at the beginning of these partnerships? What is the response by them?
And let me go first with that and throw a spanner in there, because not so long ago we had a conversation similar to this with the Vice Chancellor in a different setting, in a different talk. And the thing that came out strongly was that as African institutions, we also need to fund African projects and African research and African studies. It's not enough to say this is the agenda. Let's go and look for money from Europe, because the funder tells you what they want you to do with the money. The funder wants the recognition, they stipulate. unless as African institutions, governments, business, private, etc., are willing to put more money into these partnerships and funding education and the research projects, we're never going to be at, it'll be very difficult to have equal partnerships if we're not willing to put the money up ourselves to do this. And so I've had some very unique experiences, even just over the past few months, where other African institutions come to us to say, we would like to do this. We've got money to run this project, and this is the skill set that you have as UCT and would like to partner with along that. And that, for me, has been very encouraging, because the partnership is driven by the country that has a need, and they've identified a skill set that we have that we could use to help them achieve what they want to achieve. Yeah, but I'll hand over to the other speakers to build on that.
Yeah, I think, sorry, let me put my video on here. Yeah, just to make a number of points. I think Salome makes a very important point about, I think we also have to perhaps rethink the poverty narrative, okay? Because often our poverty is about choices we as countries, as health systems make about how we are going to spend whatever resources we do have. And so, what ends up happening in many of our countries is that there is a clear misalignment and malalignment of how we spend what we do have. And if we perhaps reprioritize those, we can find that the amount of funding we're able to raise and contribute, and the programs that we're able to reprioritize to delivering appropriate healthcare, to delivering appropriate surgical care is very much there. And in fact, one of the things that the Lancet Commission highlights is, that this mindset that says that surgery is expensive, or basic surgery is expensive, and many of these healthcare interventions are expensive, of course, based on a very false logic. And that, of course, investing in the appropriate infrastructure, education, implementation is actually important and good for society. It's good for communities. It brings back people who suffer prematurely, whether it's breadwinners or others, back into society as breadwinners. And the upside of it is of course very important. So there is the mindset shift is on both sides. There's clearly a HIC mindset shift that needs to happen, and I think the way we approach many of these problems, including how we see funding, is also crucially important. But I also think, you talked about what is the response of funders. Often it's very variable, but I have been quite struck by how having the bold conversations with these people is often very fruitful. So people come with a particular lens, with a particular framework, with a particular perception, and many are open to understanding that there's a lot of value in equitable and ethical and reciprocal partnerships and relationships, and that we can make them win-win-win if we sort of rethink their structure, how they're funding, et cetera, et cetera. So again, I think if many of these things are put on the table upfront, discussed, and boldly unpacked for what they are, that people are willing to part with funds and aren't necessarily as dogmatic about how they want their resources and funds to be spent. So yeah. Lydia?
Thanks, Regan. That's a good question. I'll try to be brief. I think I don't think we've really tested it enough to know what the response will be, and I think that there is increasing space for that kind of conversation. I don't think we must be naive that just requesting and asking for a change is going to mean that it happens. I think it's going to require an advocacy about how global research is organized. Because the more we talk about that in the public spaces, and in public in the space would be editorials, opinion pieces within journals, that there's accountability for people who are raising funds on global health programs, that those funds need to be used for locally initiated and relevant projects. And I think within the global north that perception is shifting as well, but it's something that we need to continue to advocate for. And I think one of the things we can do is to be able to set our own research agenda. And I think that we are not strong enough about that. So we tend to be subsumed in the research agenda of other countries. You know, we have a massive clinical burden and load, and we are under-resourced from a HR point of view. But having our own research agenda helps to reset some of that power dynamic. But I think we mustn't think that this will be necessarily an easy thing. We need to start having the conversations, and we also need to start doing advocacy around it in different spaces. And I think the university has a massive role to play in this, because the way we train our young researchers is to believe that there is a goodness in the foreign and the international, which is not here. And we need to shift that ideology in practice in the way that we support and promote our local academics.
Yeah, I have a question here that I think follows on really nicely to what you said at the end there, Prof. Cairncross. It's that many young researchers find themselves in a situation where a powerful global north partner or investigator is their partner, and as they evolve as emerging researchers, so sort of your career is intertwined with how your partner progresses as well. What advice do you give to these young emerging researchers or clinicians as they navigate their path?
I think it's to find strong African partners, and that may not be South African partners, but partners elsewhere on the continent, so that you don't have a unidirectional flow to your career, but there's more than one thing that is happening, and most people are doing different kinds of research in different areas, but you should not really be linked just to one. I mean, those partnerships happen, and that's how many people launch their careers, and in the beginning you are starry-eyed because there's this big institution doing this thing. But if we begin to understand that, yes, it's great that they want me, but you know, I'm obviously contributing something great, and how do I link that to a local partner or a strong local researcher that can help me to shift that dynamic? Because obviously as a young emerging researcher, it's difficult to do that on your own. So find a strong local partner is my answer.
And practically, some of the things that we're doing in global surgery. So we've got the MSc Global Surgery, we've got PhD, we've got students who have applied to do PhDs with us. And for those who want really a high income plus low middle income experience, we are partnering. You know, there's a few studies that I'm doing that I'm supervising with an Oxford co-supervisor, or working with somebody in Harvard or wherever. We open to those, because we're not just saying at the end of the day, you know, this is all we want to give you, but how can we support students so that they get both sides of the coin, and give them the excellence that they want from an African perspective, from a high income country perspective, but let's all work together as a team so that the student walks away with the best of both worlds, and with the support that they can get from both sides. So that is possible and feasible.
And sorry, Regan, maybe just to add on to that, I forgot to mention, I think it's important to know that global surgery is not only about health that's being done well in the north and not being done well here. Within all countries, these inequalities exist. They exist here in South Africa, and they exist in the US, they exist in Canada. So it's, you know, if we have partnerships, it's also how we're addressing marginalized indigenous communities in high-income countries as part of global surgery research and implementation. So it's not only a kind of a rescue of the South, but that every single country has these problems, and that when we're working with our partners, we need to have a recognition of the inequalities within their countries and how they are working to combat that, and what lessons can they learn from us as LMICs about how to manage that inequality within countries, not just between countries.
Yeah. I don't really have much to add, except to say that I do think it's about a balance. I do think we shouldn't also forget that many of these northern partners have a lot to offer. There's a lot to learn from them that we can really benefit from, and that our societies can benefit from. And whether it's particular research skills or technological advancements or different innovations that we can apply locally, that there is, you know, it's a balance. As long as you as an individual can understand what your long-term interests and goals are, and how perhaps you might be able to take on board what you are getting from the North and be able to apply it here. So you know, I think there's a balance, and it is important to remember that there's a lot to give and take both ways. Yeah.
Yeah, thank you so much for that. One of the topics or points that Prof. Cairncross made in her presentation is that we must be aware of sort of perpetuating these power dynamics as South Africa and as South African institutions when we do work with other people from our continents. What sort of advice would you give to people who are wanting to do this sort of collaborative South-South partnerships, but do it in a way that is healthy, sustainable, and good for all involved? I know, Prof. Ntsekhe, I mean, you've done so much work in heart disease with this. Do you have any advice for these types of people?
Yes, look, I mean, I think it's very much so, you know, as I started out in my thing, every relationship has a power dynamic. You know, there's an important history that we bring to all partnerships, all relationships. And in many instances, as we form these partnerships with South-South partnerships with the rest of Africa, we, in a funny way, replicate that dynamic that happens with the global North. We are the ones with the resources. We are the ones with the universities. We are the ones that might get career advancements through the research that we conduct, et cetera, et cetera. So again, you know, what's good for the goose is clearly good for the gander. We need to be incredibly conscious of that as we enter these spaces, as we enter these relationships, and be bold about speaking to them. Be very intentional about making sure that there is equity, that there is reciprocity, that there's clear agreement about you know, what the relationship is about, who's going to get what and why and how, and what the long-term goals are and the purpose of doing this. I think in many instances, it is sadly true that we as South Africans in particular have got it wrong, and have had to learn the hard way that, you know, we have very proud brothers and sisters up north, and we are not the bearers of truth and whatever else is required. And so, yes, I think, you know, a great deal of humility is required as we engage these partnerships, and just to keep that in mind. Yeah.
Do you have anything to add, Prof. Mpiko or Prof. Cairncross on this question?
Just to give a practical example of a project that we are hoping to start, that we don't have funding for, is we were approached by a cancer organization, Aortic, which is an African organization looking at research and training in cancer, to run surgical oncology training fellowships here. And it would be very easy for us just to design a curriculum and people come and then we train them. But the correct thing to do is actually to take the long planning strategy, which would be first to understand the context of where surgeons are going to be working. What is it that people want to learn? Which cancers are a problem? and what facilities are available, so that the training becomes tailored to what is actually needed rather than what we think should be given. So even where someone is requesting a partnership for training from somewhere else, the way that you engage with that is important. And keeping the lens that we're all learning as we teach. So the teacher is learning and the learner is teaching at all times. And that is really applicable and true in every single situation, whether it be a students having a lecture on a health issue, which you wouldn't believe that the lecturer can learn anything from the students. That is not true. There is always a bi-directional component to learning. And I think that if we begin to change our pedagogy, we'll begin to change that mindset in the way that we work with others. So it can't just be a stated, yes, we're equal partners and we're listening to you, but it needs to be internalized and believed that actually we are always learning from others when we're learning, and we're teaching others as we're learning. And so if that partnership works out, it would need to be long-term partnership. So it's not a swoop in, sweep out, or you come, you train and you go and there's no relationship. So I think it's long-term planning, no quick fix solutions. And as Mpiko says, it's humility on both sides of the table, whether we're on the slightly more resourced side of the table in a particular partnership or the less resourced side of the partnership. It requires the same reciprocal respect and kind of honoring of the other knowledge at all times, which doesn't really exist globally at the moment within these partnerships. But as we say, hopefully they are changing and beginning to do so.
Yeah, thank you so much to both speakers and to Prof. Mswina for that really rich discussion. I feel like I'm selling the attendees short because there are like 5 or 6 more questions that have been asked that we could really dig into this evening. But our time has unfortunately run out, so I'm going to hand over to Prof. Mswina to say a few words before concluding.
All right. Thank you as well to both speakers for just such excellent thought-provoking talks. I mean, these were really difficult conversations, but this is what this is all about. This is what global surgery is all about. And I think wanting to have these honest conversations as we plan what we want to do, where we're going, and the whole theme of reimagining global surgery, I think that comes out, keeps coming up each time we have conversations like this and talk about the way we've been doing things in the past and the way that we need to do things. So medicine, how surgery is taught, etc., needs to evolve, and these conversations help us and remind us of what needs to change and what we need to put emphasis on. I also want to thank, everyone, the Surgical Student Society for partnering with us in putting this together. I want to thank, the international community, especially today, that has joined this conversation. We see a number of members of the international community from other universities all over the world, and also the UCT staff as well, and students that have joined. But 3 things that I want to pick from today's from the conversations, from the presentations we've had, is the one question is whose problem are we solving? At the heart of every partnership, at the heart of everything we do, we need to ask ourselves, whose problem are we actually solving? Are we taking what we think is a problem and going to just, trying to partner with people so that we can solve, something that we imagine could be a problem? Or are we really partnering so that we can solve a real problem that is there, that is going to improve the lives of the people that we're working with? And so I think in these partnerships, we always need to think about that. And that goes back to the agenda setting. But we cannot move forward with global surgery and global health partnerships if we don't put, the problem, the crisis, the thing that we're trying to solve as at the center of what we're doing, so that we focus the right attention and focus on needs of the communities and the people that we're working with. the second thing that I want to highlight was just the patient-centered, community-centered, and country-centered approach that Lydia mentioned in her talk. And lastly, just an encouragement to students who will want to get involved in these global on these traveling the world, getting involved in electives, etc. across the world. You need to think about, am I going there to learn, or am I just going there to see? And that's likewise to students who are coming to us, who want to spend time with us in Cape Town. Are you coming here to learn something from us, or are you just coming to see? And that's moving away from just having an African experience or a tourism kind of experience, versus really coming to engage and seeing where you can contribute and where you can help, and where you can also even perhaps teach us things that we may not be familiar with. So on that note, I again just want to say thank you to the speakers. Thank you to Regan for putting this together. And I'm gonna hand over to Savannah to close off.
Thank you so much, Prof. Ntsekhe, for opening so nicely for us and closing off so succinctly, and just summarizing what has been discussed this evening into some easy points to remember and to think on further. And then on behalf of the UCT Surgical Society, I also just wanted to say a big thank you to our two speakers who joined us this evening, Prof. Ntsekhe and Prof. Cairncross. And thank you so much for looking at what it means to really reset the power dynamics in global partnerships this evening. Prof. Ntsekhe, I thoroughly enjoyed hearing about PASCA, and it has made me really excited about the future of South-South partnerships in lower middle income countries, and particularly in South Africa in our own context. And Prof. Cairncross, thank you so much for outlining for us the numerous political influences that have an impact on healthcare, and for giving us some important insight into what it really means and what it looks like to reset global inequities and research agendas in our context. I definitely think both speakers have given us some food for thought, so thank you for that. Lastly, I also wanted to say thank you to everyone who joined us this evening. As Prof. Ntsekhe said, from far and wide, we really appreciate you attending this talk, and we trust that you enjoyed it. We also hope that you'll join us for the next talk in this webinar series, where Dr. Shrikant Peters and Dr. Rowan Dace will be discussing the practical implementation and management approach to global surgery and the operating theatre. So the date for the next talk has not yet been confirmed, but please keep checking our social media pages for updates, and it will be happening within the next month. Once again, thank you so much to everyone for joining us this evening, and I hope you have a wonderful evening, and you're welcome to leave the Zoom call now.
Thank you, everybody.
Thank you, everyone. Thank you.